I'm Katie Zhang. I'm one of the cardiologists here at Washington University and part of the Amyloid Center of Excellence. I'm very excited to introduce our next speaker for today's program, Dr. Ron Witteles from Stanford University. Dr. Witteles earned his BA from Northwestern University and MD from the University of Chicago Pritzker School of Medicine. He then moved to Stanford University, where he completed internal medicine residency and cardiovascular medicine fellowship training, and also served as chief resident and chief fellow. Upon completion of training, he joined the heart failure faculty at Stanford, where he is now appointed as professor of cardiovascular medicine. He serves as program director of the internal medicine residency training program, which is the largest GME program at Stanford. He is responsible for the residency training of over 140 residents each year. In addition, he founded and serves as co-director of both the Stanford Amyloid Center, which is the largest amyloid center in the Western United States, as well as the Stanford Multidisciplinary Sarcoidosis Program. He has been active in the field of cardio-oncology for many years and serves as an associate editor for JACC Cardio-Oncology. So welcome, Dr. Witteles.
Thanks so much, and thanks for the opportunity to join this great meeting. This is the one good thing about the pandemic is it allows us to do so much of this over Zoom and virtually join one another. So let me go ahead and share my slides. Okay, hopefully that's working well. And I'm going to be speaking for the next 30 minutes or so on developing therapies for ATTR amyloidosis. So I'd like to start with two questions to get us thinking. So the first is a 50-year-old woman with a heterozygous transthyretin V30M mutation, and she has quickly progressive symptomatic polyneuropathy. Her cardiac imaging shows classic signs of amyloid infiltration, but she doesn't have any current cardiac symptoms. So what's the best therapy to initiate? You see the choices: diflunisal, patisiran, tafamidis, patisiran and tafamidis, or a liver transplant evaluation. Maybe we can see the answers. Okay, so a mixed bag. The option B, patisiran, is the winner. Option C is just shortly behind. Thank you. And I would say that the answer to this, there's two reasonable answers in my opinion. I think my preferred answer would actually be option D, patisiran and tafamidis, although I think patisiran alone would be a reasonable choice as well. We're going to see during the talk, hopefully, why this is the case. Let's move on to question 2. So a 45-year-old man whose father died from cardiomyopathy and neuropathy due to the T60A mutation has learned that he's a gene mutation carrier. However, careful neurologic examination reveals no evidence of neuropathy, and he has a thorough evaluation with echo, EKG, troponin, NT-BNP, and PYP scan, which are all normal. So what's the best therapy to initiate? And we have all those same choices as before, plus an option for no therapy. Give you a few moments. Okay, can we see the results, please? Okay, so most people said no therapy, with a smaller number saying diflunisal, and I think that's good, as I think those are the two reasonable options here. I would actually lean towards diflunisal as my choice, though I think no therapy is reasonable as well. And we'll hopefully again cover all of these points during the next 30 minutes or so. And if there's any questions after that, we can get to them in the Q&A. So let's start with transthyretin, what it is. So it's a protein that transports thyroxine and retinol, hence transthyretin. Its primary source, in fact, almost exclusive source, is from the liver. And it almost completely circulates in the circulation as a tetramer, as you can see in that ribbon diagram in the upper right. But it's in steady state at any given time with a monomeric form, so single units rather than these 4 units bound together. When thyroxine binds to it, it actually stabilizes the tetrameric form. Now, importantly, the monomeric form is inherently amyloidogenic, meaning it is prone to misfolds and deposits. And in the wild type, i.e. non-hereditary form of the disease, that's exactly what happens. The normal transthyretin protein in its monomeric form circulates, misfolds, and deposits. For reasons that are unclear, this happens much more in men than in women, but women can certainly get the disease as well. In addition, people can be born having inherited mutations in transthyretin, which destabilize it, have it be more likely to be in the monomeric form, and therefore make it more amyloidogenic. Now, this is not a talk going over the pathophysiology of transthyretin amyloidosis. It's going to focus on therapies. But as we'll see, I think that structure is relevant as we think about the therapies. So traditionally, there was this view. For the wild type form of the disease, there was really nothing that could be done other than supportive therapy. Whereas for the hereditary, or what's sometimes called variant form of the disease, you could think about doing an early liver transplant. And the rationale there is that transthyretin is almost exclusively produced by the liver, so that if you replace the liver, you're taking away the source of the mutated protein, and you'd slow or halt disease progression. And indeed, this was used quite reasonably commonly, particularly in Europe, for the hereditary polyneuropathy, or FAP, familial amyloid polyneuropathy form of the disease. And that's because it could be a devastating progressive disease. Once it started, it could really gallop along quite quickly, often would have an early age of onset, and there was nothing else you could really do. You couldn't obviously transplant the nerves, and this was something that could be done to halt it. Now, interestingly, they would then typically take the recipient's liver and actually use that liver and give that to somebody else on the liver transplant list who had cirrhosis. And you'd say, well, that's not very nice to the poor patient with cirrhosis who's getting a liver that produces mutant transthyretin protein. But remember, it takes decades to actually have enough misfolding and deposition to develop the disease, which was beyond the lifespan of somebody with a liver transplant. So that was done routinely, called domino transplantation, but obviously had all the downsides that come with organ transplantation. And so there was a lot of interest in pharmacologic therapies. And so there have been two main strategies that have focused on how to do this. The first is to bind to the thyroxine binding site of that tetrameric form, and therefore stabilize the transthyretin protein and not have the monomers deposits. And there's some therapies we'll talk about for that. The other idea is to say, what if we just knock down the liver's production, or what's sometimes called the silencing approach of transthyretin? And there's therapies we'll talk about for that. And then finally, there's a third strategy to say, can we actually have an antibody bind to the amyloid fibrils and remove them? And there's a bit of early work in that we'll talk about. So what I'd like to do is go through largely chronologically and look at the trials so that we can understand how this has progressed, and just see how remarkable the advances have been over the last decade or so. So the first important trial was this one, which was with the agent tafamidis, which of course we'll come back to, for the polyneuropathy, the hereditary polyneuropathy form of the disease. And it's an interesting study, not only because of the results, but because it shows how a critical error in clinical trial design can really sink a trial. So what they did is they took 128 patients with the polyneuropathy form of the disease due to the most common mutation that causes the polyneuropathy form of the disease, called V30M. And they randomized patients to tafamidis or placebo for 18 months. And they said, they predefined that a primary endpoint was if you were a quote unquote responder versus a non-responder. And they had criteria for that. The mistake was they said that if you got a liver transplant during the study, then by definition, you were a non-responder. And the problem with that is that almost 70% of patients were on the liver transplant list at the start of the study. And getting a transplant had nothing to do with responding or not to the drug. It was just that their number came up on the list. And so sure enough, 21% of patients during the course of the study were transplanted. Now, by pure lucky coincidence, that ended up being evenly divided between the tafamidis and the placebo arm. But of course, what it did was it lowered the power of the trial. And as karma would have it, if you look at the intention to treat analysis on the left, though it seems like the tafamidis arm is doing better as responders, you'll note that it just misses hitting a statistical significance with a p-value of 0.068. If you look at the secondary endpoints, which I'm not going to go through in detail, suffice it to say that they all seem to clearly be favoring the tafamidis arm. So now put yourself in the shoes of the regulatory authorities. On one hand, you have a study that missed its primary endpoint. On the other hand, it seemed like it was doing something favorable, and there was no other therapy for what could be this devastating disease. So the European Medicines Agency looked at the data and gave a thumbs up on approval. The similar agency in Japan looked at it and gave a thumbs up on approval. And of course, you know where this is going. The FDA looked at it and said, no thanks. And it was not approved in the US and is not approved in the US for that indication. So the next important study was this one here, and it took advantage of the fortuitous fact that many non-steroidal anti-inflammatory drugs bind to that same thyroxine binding site and stabilize the tetrameric form of transthyretin. And the one that does so the most is an agent called diflunisal, which is an FDA-approved NSAID for arthritis pain. It's been around for a long time. I don't think many of us use it that much, but it's around, it's cheap, and it is the most effective at binding to transthyretin. And so these investigators performed a really nice double-blind placebo-controlled clinical trial for, once again, the hereditary polyneuropathy form of the disease. And it was published in JAMA a little more than 7 years ago. And here's the results. And what you can see is that it was actually quite effective. So what you see on the y-axis is something called the neuropathy impairment score. Now, as a group here of mainly cardiologists, I imagine most people are not familiar with the neuropathy impairment score, and that's fine. But suffice it to say, it's a well-validated objective scoring system for degree of polyneuropathy. The higher the number, the worse the polyneuropathy is. So what they're looking on the y-axis here is the change from baseline. And what you can see is that at 1 year, and then particularly at 2 years, there was a very large difference in progression of the disease with placebo versus diflunisal. Now, it's important to note, the diflunisal arm progressed as well. So this was not a cure of the disease, nor did it halt progression, but it really slowed progression. And the nice thing with diflunisal is that it's a cheap, generic, non-steroidal anti-inflammatory drug. And it's based on this data that I will often use it in mutation carriers who don't yet have symptomatic disease, although we don't have clear evidence justifying that, but it probably makes sense. Now, the problem, of course, with diflunisal for people with cardiac disease is we know non-steroidal anti-inflammatory drugs are relatively contraindicated in patients with heart failure, and therefore are probably never going to be the answer in this disease for the cardiac form. So now we should move on to the knockdown agents. These are the agents that, again, cause the liver to not produce as much transthyretin. And there's a couple of different approaches. They are different in how they actually work, but they end up achieving the same net result, which is a significant reduction in the production of transthyretin by the liver. And there were two similar approaches attempted, one called patisiran and one called inotersen. So let's look at patisiran first, and with the landmark Apollo trial. So this was 225 patients with the hereditary, or what's sometimes called variant form of transthyretin, again, polyneuropathy. And they randomized them to patisiran versus placebo. Now, patisiran, you'll note, is rather inconvenient. It's an every 3-week intravenous infusion. It was double-blind, and they used that same neuropathy impairment score as the primary endpoint at 18 months. It was well tolerated. There were only mild infusion reactions, and the results, I would say, were nothing short of spectacular. So here is the primary endpoint, the neuropathy impairment score on the y-axis. And what you can see here is a couple of things. So first of all, if you look at the red line, notice how placebo is just galloping along, such that by 18 months, you've seen an increase by 28 points on the score. Now look at the blue line, patisiran. Not only did it slow progression, it actually did better than that, and you actually had some regression of disease based on the neuropathy impairment score, such that the average patient actually dropped by 6 points on the score by 18 months. So a difference between patisiran and placebo of about 34 points on the score. Now, again, I realize we're mainly cardiologists here and may not know the neuropathy impairment score very well, so let me put it in some different terms. So the average patient with diabetic neuropathy, a bad disease, I think we can all agree, progresses at 3 points per year on average on this score. This is a difference of 34 points at 18 months, just massive. This is the difference between being able to walk and not, the difference being able to get to the bathroom and take care of oneself and not, just a massive difference. And what's more, is look at this p-value. So you're reading that right. That's a p-value of 10 to the minus 24th. For a trial of 225 patients. I did a little back of the envelope calculating. So how low is this p-value? So I've listed some of the major heart failure trials with carvedilol, enalapril, metoprolol. And you see these are 2,000, 3,000, 4,000 patient trials and seem to have impressive p-values until you see this. So put another way, the results of this trial is about 1,000 million trillion times more likely to be real and true than those major heart failure trials, and all achieved with an N of only 225. Or another way of looking at it is that, at least according to Wikipedia, there's approximately 7.5 times 10 to the 18th grains of sand on the Earth. So now imagine you have 1 million Earths and you take the sand from all of these million Earths and you put it in a gigantic pile. And then you have two people randomly choosing a single grain of sand from these million Earths. The chances that this result isn't true would be the chances of the two people randomly picking that exact same single grain. So you may remember Jim Carrey saying, "You're telling me there's a chance." I'm going to say no. Here, there's no chance. This is a real result. It's rather remarkable. There was a cardiac sub-study from that same study. Remember, it was a polyneuropathy study. And where they said if you had a thick ventricle, 13 millimeters or more, and no history of aortic valve disease or hypertension, the presumption is that they had some cardiac involvement as well. Though again, these are not heart failure patients. This was a polyneuropathy study. And in that population, they did echoes and they found a clear signal showing that it seems to be helping from the cardiac form of the disease as well. So you can see, looking at LV wall thickness or global longitudinal strain or end diastolic volume or cardiac output, all of this seems to clearly be favoring the patisiran arm. In that same study, they also looked at NT-proBNP, and though the values aren't that high to begin with, because again, this is mainly a polyneuropathy study, you can see a clear separation that occurs in between the placebo and the patisiran arms, and once again, with a very impressive p-value. If you looked at all-cause hospitalization and mortality, once again, you can see the patisiran arm in the blue versus the gray placebo, clearly favoring the patisiran arm. And same thing if you looked at cardiac hospitalization and all-cause mortality. So really just a amazing trial results. Now, this was the result from the other trial, which, if it wasn't for having patisiran, would have been, I think, considered a grand slam as well because of how impressive it was. So this was with the other agent, inotersen. This had 172 patients, so slightly smaller than Apollo, and it was for a slightly shorter but pretty similar length of time. And once again, it was a polyneuropathy study, patients randomized to receive inotersen or a placebo. And what you can see is, again, the results look pretty impressive, look actually really impressive. You can see the difference in that neuropathy impairment score of almost 20. Although, again, when you compare that to 34 or so, it's maybe not quite as impressive. And what's more is that though it's more convenient to give them patisiran because it's weekly subcutaneous rather than the every 3-week intravenous, there were some safety concerns around thrombocytopenia, glomerulonephritis, and even what seems to be a potential imbalance in deaths, although remember it was randomized 2-to-1. What's more, if you looked at they had some cardiac studies as well, again, in this polyneuropathy study, and it did seem that whether you looked at the entire cohort or a cardiac subgroup, you did not see those same degree of impressive differences in things like wall thickness and mass and global longitudinal strain. So I would say when you look at this data, it seemed more promising overall with patisiran. And we're comparing a little apples to oranges because they're, of course, two different trials. If you put them side by side, again, at least to my read, the overall patisiran results were more impressive, although, again, taken in isolation, the inotersen results were really quite impressive as well. There did seem to be greater mean TTR reduction with patisiran, and it could be that that's the reason why. Okay, well, again, we're mainly cardiologists here. Too much neuropathy talk. Let's talk about the heart. So this, of course, was the landmark ATTRACT study, or tafamidis for ATTR cardiomyopathy. And I want to emphasize, just how much of of shooting for the moon this trial was. And so this is a randomized phase 3 double-blind placebo-controlled clinical trial. It was broad. It was wild type or the hereditary familial patients. It was large for an amyloid study. It was 441 patients worldwide followed for 2.5 years. And look how hard a primary endpoint was chosen. No 6-minute walk time as the primary endpoint, or 6-minute walk distance. This was mortality and cardiovascular hospitalization in the tiered endpoints. And you see the key secondary endpoints of quality of life and 6-minute walk. And so I think a lot of us worried when this trial started that we were going to see a type 2 error and we were just going to fail to detect the difference in something that was that worked. But we were wrong. Boy, did it detect a difference. It was a really successful study. And here's the primary endpoint. You can see how positive it was. But if we break it down into its components, here's patients alive at month 30, so the hardest of hard endpoints. And look at the difference, the absolute difference of 13%, or put another way, a number needed to treat to prevent one death at 30 months of only 7.5 for this extremely well-tolerated once-a-day oral therapy. So just a massive treatment effect. If we look at the curves, interestingly, they stay about the same until about month 15 or 18, and then they start separating, and they keep separating as the trial progresses. How about cardiovascular hospitalizations, another hard endpoint? Well, you see the numbers there. Those are numbers per year, or put another way, the number needed to treat to prevent one hospitalization each year, only 4.5. So just a massive treatment effect. And here's the time to first cardiovascular hospitalization. And here, interestingly, you see the curve staying right around the same until around month 8 or 9, and then they separate, and they keep separating. This was an interesting fact, which was the subgroup analysis looking at NYHA class, whether people at baseline had NYHA class 1 or 2 versus class 3. And what it showed is that clearly the drug had a larger treatment effect by far in the earlier stage patients, the class 1 or 2 patients versus class 3. And that's different if you think about it from most drugs where they have the biggest treatment effect in patients with more severe disease. So if you needed any more reason to understand the importance of early diagnosis of the disease, this is it. If you look at the secondary analyses, 6-minute walk test, you see these curves started separating from the very beginning in favor of tafamidis, and the same thing we see with quality of life. Now, I'll make the point that tafamidis does not stop the disease progression, and it certainly doesn't reverse any of the disease. And it's very important when you start patients on this drug to set expectations. They are not going to feel better because you started them on tafamidis, but you're going to really slow the decline in a meaningful way from both a quality of life and a quantity of life standpoint. And if we get into safety, it was remarkable. There was really no adverse events at higher rates than in placebo. More people discontinued placebo for so-called adverse events, which were undoubtedly progression of their heart failure. There's no dosing issues in renal dysfunction. There's no labs that need to be followed. It was really about as clean as you could get. This is looking at NT-proBNP, and you can see I'm showing it here, taking the placebo group minus the tafamidis group, the levels of NT-proBNP, and you see that at month 0, of course, baseline, they're right around the same, and you see they just skyrocket in the placebo arm over time compared to the tafamidis arm. So really successful drug. The one big caveat that most people are probably aware of is that it's extraordinarily expensive, and so it has a price tag of $225,000 a year, which I think all of us in the field wish was much less. And though most patients you can get started on it, and most or all of the costs will end up being covered, or often there's foundation help. It's a real issue, and among other reasons, I think many even more reason we'd love to see some more competition in this space to bring down the cost. That brings us to another agent that works similarly to tafamidis, that binds to the thyroxine binding site, called AG10, or it also now goes by the name of acoramidis. It was actually developed at Stanford in the lab of Isabella Graef, who did high throughput screening of different ligands, seeing what bound to that site and really stabilized TTR the best. And it turned out this agent called AG10 did. And it has significantly higher affinity to stabilize than either diflunisal or tafamidis. There was a phase 2 study that was performed, 49 patients who were randomized to 2 different doses of AG10 versus placebo. And you can see really impressive TTR stabilization with that highest dose, 92% stabilization at the trough and 96% stabilization at the peak. And this agent is now in phase 3 trials for both cardiomyopathy and polyneuropathy that I'll mention in just a moment. What else is on the horizon? Well, a lot of excitement about this agent, vutrisiran, which is the second generation form of patisiran, which was that one that had those amazing results in polyneuropathy. And the nice thing about this is you've changed the Q3 week intravenous dosing of patisiran into a Q3 month subcutaneous dosing with vutrisiran. No pre-meds are needed. And so there's 2 studies with that, one called Helios A for polyneuropathy and one called Helios B for cardiomyopathy. The polyneuropathy one is an open label study comparing vutrisiran to both patisiran as well as placebo. They're not actually giving placebo now because that would be unethical, but they're looking at the placebo arm from the patisiran study. These results have been announced by press release, which I'll show you on the next slide, although have not yet been published. Helios B is ongoing. It is a study that I think those of us in heart failure are very excited about, with 600 participants, and it's a randomized, double-blind, placebo-controlled clinical trial with, again, a hard primary endpoint, and a subset of the patients are allowed to be on tafamidis at baseline and still be in this study. So we'll get some data not only of how effective this is or isn't, but is it additive on top of tafamidis. The results from Helios A, as I mentioned, this is the polyneuropathy study, were just announced by press release in January. And basically, it met all of its endpoints when you were comparing it to that placebo arm from the patisiran trial, including exploratory endpoints looking at NT-proBNP. And just as importantly, it seemed to be quite safe and well tolerated per the data that's given. Again, this is press release, so of course, we all look forward to seeing the actual full data in publication. How about other approaches? Well, gene editing. If you can knock down production by gene editing, maybe you could get a one-time treatment and really just knock out the liver's production of TTR, or really knock it down. You wonder, is that okay? I mean, do we need TTR? There's a reason, presumably, why we all make it. And the answer is, you'd assume so, but we've yet to really see negative results in anybody from, knocking down TTR too much. So there's a phase 1 trial of 38 participants with the polyneuropathy form of this disease that is currently ongoing. This is another approach. This is an antibody-based approach, which is trying to bind to amyloid fibrils, maybe even ones that have already deposited, as well as soluble forms of the misfolded aggregates before deposition, and say, can we actually remove amyloid deposits that are there? So this is being studied as well. I think it's important to note that a similar agent, an antibody-based approach in AL amyloidosis, basically failed in a phase 3 trial, although there's a subgroup analysis that said maybe it helped in people with more severe disease, and that is being further investigated in a phase 3 trial. But from TTR, this agent PRX004 has recently completed a phase 1 trial, which once again was reported in a press release, not yet published. And this is the press release results, which I would say at first sound good. I think when you look at it with a bigger magnifying glass, it's hard to say much about it, honestly. You had 21 patients, and then they said, well, we're going to look at 17 who are in a long-term extension study, and then of those, we're going to only look at those who are on the high dose, and then of those, we're only going to look at those who finished a 9-month infusion. And so if you look at that selected 7 patients, maybe there seemed to be some favorable results, although obviously it's a phase 1 study, there's no placebo arm. So I think most importantly, it doesn't sound like there were important safety events, and so we'll see what really happens with this in phase 2 and 3 studies. Here are current phase 3 TTR trials, which is amazing for a disease that had no therapies just a few years ago. So I mentioned AG10 has both a polyneuropathy and cardiomyopathy trial. Patisiran itself has a cardiomyopathy study, but I think there's more excitement about the second generation form, the vutrisiran, which again recently announced positive results for Helios-A, and Helios-B is ongoing. And then very importantly, you also have this agent, which is basically the second generation form of inotersen, which is a monthly subcutaneous injection, which also there's good reason to believe will not have those same problems with thrombocytopenia and glomerulonephritis, and that agent called Axia TTR LRX, and that is being studied for both polyneuropathy in a trial called NEURO-TTR or T-Transform, and ATTR cardiomyopathy for Cardio T-Transform. All right, I just want to close with asking a question: who should be screened with transthyretin cardiomyopathy? And so if you think about characteristics of a good screening test, it should have a high prevalence of the condition being screened, it should have an accurate and non-invasive test easily available, and you should have effective treatments available if a diagnosis is made. So though in this talk, we didn't talk about the first two parts, hopefully you're all aware from your prior knowledge and prior talks today that in an older population, there is a high prevalence of TTR cardiomyopathy. And we do have an accurate and non-invasive screening test easily available. So a group of us came together in late 2018 and made the recommendations of saying we should actually screen for this pretty broadly. So all it should take is really heart failure or any red flag symptoms like carpal tunnel, but really just heart failure and a thick heart, which we defined as 14 millimeters or more, who meet the age criteria that you see there on the right, should get screened. And as hopefully everybody knows by now, that screening is a two-part screening, ruling out a monoclonal protein with a serum-free light chain ratio and a serum and urine protein electrophoresis with immunofixation, and then the bone scintigraphy testing, which in the United States is with a PYP scan. All right, so I like to say that ATTR amyloidosis is the unrare rare disease. It is not rare, again, particularly the wild type form. It is not hard to diagnose. There's a simple algorithm, as we just discussed. And most importantly, and relevant for this talk, is we now have effective treatments. For the variant or hereditary form of TTR polyneuropathy, patisiran, inotersen, and diflunisal are all good options. For ATTR cardiomyopathy, currently the only approved is tafamidis, but there's so much in the future, more stabilizers like AG10, better silencer delivery, gene editing, antibody-based approaches. And the future is bright because it's a great example of having an understanding of the pathophysiology leading to effective therapies, and we have every reason to believe outcomes will continue to improve. I'll just close by noting that Dan and I are privileged to both be editors on the editorial board for JACC Cardio-Oncology, and there's a special issue for amyloidosis coming out this winter. And so I encourage everybody to read it when it comes out, and anybody who's doing research in the area, please consider submitting by April 15th. And I will just acknowledge that I am very fortunate to work with an amazing group at the Stanford Amyloid Center. This is a disease that really requires a multidisciplinary approach. We have a wonderful group out at Stanford, as I know you all do at WashU. So thanks again for the opportunity to present.
Thanks very much, Dr. Witteles, for such a fantastic talk. I've heard you speak before, and it's always very educational and informative. So everyone in the audience, feel free to either raise your hand or type questions into the Q&A. One question that's come in so far for Dr. Witteles, how do you follow patients who are getting treatment? And do you use biomarkers, 6-minute walk test? And then also, how do you modify your therapy based on these results?
Sure. And obviously here we're talking about ATTR, not AL amyloidosis. So for ATTR amyloidosis, I actually think that there is not currently a good role for doing tests to quote unquote follow them, because we don't have a way to modify therapy. So, and so we don't have a way to say somebody is failing, right? So let's say that you put them on the current standard of care, tafamidis, and then they decline over the next year. Well, we expect them to decline, as showed. And we don't really know for an individual patient what rate they should have of decline. So it's a tough thing to try to explain, I think, a lot of times to patients who want to know, well, is the drug working? And say, well, the way we know it works is because we have great evidence from a really well-done, randomized, double-blind, placebo-controlled trial. But we had at Stanford 30 patients enrolled in that trial, and then many more in the extension. And I can say I had no idea who was on what during the trial. I mean, not just because it was blinded, but patients just—it's not like giving penicillin to the first time when it was created and watching people's infections magically get better. They don't magically get better in front of your eyes, so you don't know. You would not know without a good trial of what to do. So echoes don't tend to progress that quickly in this disease. Biomarkers, they might get worse with time, but we kind of expect them to get worse over time. So currently, I would say there's no role for routine echoes, or even in terms of changing care, routine biomarkers.
Yeah, I think I've been in conversations with other leaders in the field who will routinely check prealbumin levels as a sign of disease response. So I guess your response would just be we wouldn't modify therapy.
Yeah, so as some people probably know, prealbumin, or again, same thing as transthyretin, when you are giving a silencer effectively, sort of counterintuitively perhaps, you'll actually see the levels rise. And of course, when you're giving a silencer, that's a stabilizer. And when you're giving a silencer, you'll see the levels fall. But again, right now for TTR cardiomyopathy, we only have one treatment you can give outside of the clinical trial setting, and that is tafamidis. So if you see it rise a little bit versus a lot, okay, you don't have another option. Now, in another world where we start having other approved therapies, and we're trying to decide between a number of very extensive therapies, then perhaps there will be a role of checking these markers. Right now, I think it's more out of scientific interest, but in terms of changing therapies for an individual patient, I don't see it right now.
So we have a few questions that relate to your MOC questions from earlier. So is there any data that combination therapy is superior to single agent therapy? So not only, patisiran plus tafamidis, but potentially inotersen plus patisiran.
Okay, so good question. So no good data. I would say it only makes sense to use agents from different classes. So things like inotersen plus patisiran wouldn't make any sense because you're giving two silencer agents, two agents that are knocking down. Using a silencer and a stabilizer, however, at least makes a lot of theoretical sense. You have one that's decreasing the production, and then another that is saying, well, what is produced, we're going to stabilize in that tetrameric form. But we don't yet have the data. Now, I said in one of the MOC questions that my general practice for somebody who has true mixed disease, real cardiac disease and real neuropathic disease, is to use the agents that we have now proven in two different clinical trials will help with each side of it. Now, the challenge is, of course, they're both really expensive, and so you have to look to make sure in terms of what the patient's out-of-pocket cost is. And I think it is certainly reasonable in 2021 to say, hey, that doesn't make sense until we have clear data. We're just going to choose one of them. I would say for people who have the real neuropathic side of the disease, that is a devastating progressive disease, and we know that tafamidis was not nearly as effective for that as patisiran and inotersen were, because we do have a tafamidis polyneuropathy trial, as we showed. So if you're going to use one agent for those patients, I would say it should be a silencer, patisiran or inotersen. But most of the time, if they have both types of both meaning cardiac and neurologic, I will use both. I will say as a final thing, for patients who have the neuropathic side of the disease, some signs of cardiac but not real heart failure, then even if I'm not going to use, say, patisiran plus tafamidis, I will generally add diflunisal, because there it's cheap and very little downside as long as they don't have real clinical heart failure.
Yeah, so Ron, just thanks for your always excellent talk, which, this was a new version. I've seen several of your other talks about amyloidosis in general, so this being more specific, I learned something new today. But the reality, the practical reality of getting, tafamidis to a patient, is so variable, and we have so much difficulty. Do you have a strategy that seems to be effective or suggested?
Yeah, and I would say, as I referenced before, the cost issue is I think unfortunate and I think frustrating to a lot of us in the field what it was published at, and I think many people have spoken to that, and that does create a real challenge, and I think it was priced for a disease that was really, really rare, that I think all of us recognize with wild type TTR amyloidosis is not really, really rare. So what does it mean? Well, people who have commercial insurance, it usually is fairly straightforward because they can usually get copays waived. However, this is mainly a Medicare age population. And most of the time with Medicare, people will have a 5% copay that they have to do, which when you do the math ends up running rough numbers, $15,000 a year, which is a lot of money. I would say for people who have truly high income, well, they can probably afford it, even though that's, nobody enjoys paying $15,000 a year, but they can mainly afford it. For people who have low income, there are foundations around the country that they can be linked in with that usually will be able to pick up the cost of the copay. And it takes some work, and but I would say from my experience, almost always comes through. I think the biggest challenge is for people who are in this middle ground where they have enough that they don't qualify, they make enough that they don't qualify for that, but where $15,000 a year is going to be a real challenge. And there's no great answer for that. I will say that, being lucky to have 2 full-time nurses who only work with patients with amyloidosis, like they've gotten very good in terms of helping them navigate to get the coverage and the resources. But that's a luxury that isn't everywhere. And, honestly, the cost needs to come down and the field needs some competition.
Yeah, no, I agree. And then I sort of wanted to test the water in terms of what you would do in a patient that we recently encountered. So he was in his 50s, early 50s, and we actually made the diagnosis of wild type TTR from carpal tunnel surgery. And, that was long before he had manifest disease, certainly from a cardiac point of view. So we did that about a year and a half ago. And then he, was confirmed to be wild type. We did a PYP scan at the time that was in between. It was basically read as negative, but it was sort of indeterminate. And I was able to get tafamidis for him just based on the biopsy, even though the biopsy from his carpal tunnel, but we didn't have clear cardiac involvement. So he got started on tafamidis, and he had been on tafamidis and taking it for over a year. And then he started to have heart failure symptoms. So I, checked EF assessment with an MRI, and he had diffuse findings on his MRI. And then his EF had dropped from previously normal to in the low 30s. And then over the next couple of weeks, his EF even got worse, and he became more symptomatic from a heart failure point of view. And this is all the while that he was on tafamidis and actually taking it. So, and he didn't really have a lot of polyneuropathy symptoms. He had the carpal tunnel, but not otherwise. And then, he didn't have a genetic mutation. So what option do we have at this point?
So, I guess I'd say first off, it's clearly a very atypical progression of the disease. And so I would first take a step back and make sure that, weren't missing like that he actually has AL amyloidosis, as well as something that would be much more likely to progress like that. But assuming obviously you'd want to make sure you did the monoclonal protein assessment. I think in a case this atypical, I might be tempted to biopsy him as well. It's just exceptionally atypical progression of wild type ATTR amyloidosis.
Yeah, actually, we did do that, and he does have cardiac amyloidosis, wild type, and.
Yeah. Okay. So, again, right now you're limited to tafamidis and then potentially clinical trials. So there's of course, the phase 3 clinical trials. And so if he qualified, he could enter one of those. If he's a transplant candidate, you could think about heart transplant. But outside of that, right now, that's what you're limited with.
Okay, great. Thanks.
I will say that this phenomenon of again, things like the carpal tunnel biopsy that shows wild type TTR amyloid and no evidence of clinical disease, and what to do in that case. There's no good answer, but that's a patient that I would start on diflunisal and then watch very closely. In the moment we could find any evidence of cardiac disease, then to switch to tafamidis.
Actually, that segues really nicely to another question that came in. Is there data that supports treating patients with mutations but no disease, clinical disease?
No data, and the problem is that to get the data, you'd have to follow so many patients for so long that who knows if and when that data will ever be available. So this is basically extrapolating from the data we have and saying, oh, look, we have an agent that honestly 250 milligrams twice daily of diflunisal is probably pretty harmless. It's maybe like taking an Advil a day, so based on the data that quite good data that shows that it prevents or slows progression of symptomatic polyneuropathy, then again, I tend to think the downside is so low, but there's no good data.
Maybe a question that Josh could field. There's a patient question that came in. Patient is getting patisiran and then also now on vutrisiran. And it seems like there was a recommendation that a liver transplant should be considered. Is there any role for liver transplantation now in this current era with all these therapeutics?
Yeah, it's a great question. I think that you probably may get a few different answers for it because there really is a lack of data in that situation. If you're getting an appropriate knockdown from your agent, then whether a transplant adds additional benefit above and beyond that may be arguable. Certainly the transplant itself would completely remove the abnormal protein as opposed to just knocking it down. So maybe better, but certainly no data to compare the two. Dr. Gilmore was on earlier, as you know, Katie, but that was before the patients were on, and discussed that, in his experience in London at the amyloid center there, sometimes they'll see insufficient knockdown with one agent versus the other, and we'll sometimes switch between anotyrosine to patisiran or vice versa. Usually they see a little bit better knockdown with patisiran than anotyrosine. So I certainly would think that it'd be reasonable to look at the level of knockdown you have and then compare that to the potential benefit of a liver transplant before making an individual decision. But Ron, do you have any other thoughts on that as well?
Yeah, no, I think that, as you said, there's no data to guide it, but I personally, when you see just how effective the knockdown agents were for the polyneuropathy form of the disease, I personally have a hard time thinking that a liver transplant for this disease in 2021 is justifiable. I think that it made great sense before we had these agents, and now I can't imagine the patient I would send for liver transplantation, but others might feel differently.
I agree with that reasoning completely.
There's one more question where the thoughts about picking up the disease before heart failure symptom onset. What strategies do you have for that?
Yeah, so I think a couple things. One is if you, for people who do have some of those red flag things, the carpal tunnel, the lumbar spinal stenosis, the biceps tendon rupture, these sorts of things, the more we spread awareness and where it's thought about in those cases, and either those tissues are stained or at least there's some basic imaging screening done afterwards, the better. And then the other thing was the screening algorithm that I briefly highlighted to say, if people have a thick heart and either heart failure or any of those red flag symptoms, screen them. Don't wait until they have end-stage heart failure, not only because obviously we'd like to get them started beforehand, but we know the treatment's not as effective. So just to think about the disease and have a low threshold for doing the screening.
Great, thanks.
So I would just add to what Ron said, because, completely agree with his group's recommendation on trying to improve our screening and thinking about it more broadly. Specifically, you want to not necessarily limit yourself to that, but just know that your chance of having amyloid is higher in that group. I know the particular question in the session right here mentions like a 12 millimeter thickness, which wouldn't meet the definition of 14 millimeter thickness. Certainly those patients may have earlier amyloid, they may have AL instead of TTR. which oftentimes has a thinner thickness on their septum. And so I absolutely want to think about it. As we expand our screening population, so as we start doing strain in more patients, it may not be quite as specific as it was in our more selected populations. And so we may have some false positives, but it will allow us to pick up a lot more of the disease that's out there that we've been missing.
We had a question or a statement come in about positive PYP scans in patients with aortic stenosis, and I think that that's a really important area that really started to grow recently. I think, certainly in the patients with aortic stenosis, you want to have your radar up for especially TTR amyloidosis, wild type TTR cardiac amyloid. But it's important to remember that in addition to ordering the PYP scan, you have to order, you have to rule out AL. So make sure you're ordering the serum free light chains and the SPEP and UPEP. We actually had a patient recently who, presented to TAVR clinic with AS, and then the TAVR physicians ordered a PYP scan, which was positive, and we saw them in amyloid clinic. This patient went as far as a cardiac biopsy because they had abnormal free light chains, and the immunofluorescence was positive for, I think it was kappa light chains, and so we were getting ready to start chemotherapy, but then the mass spec came back with TTR. So, even in the aortic stenosis patients, it's important to stick to the algorithms that have been presented earlier today to make sure you're making the right diagnosis.
Yeah, that's a great point, Katie, and a nice patient example. And I'll carry off of that sometimes the tissue taken at heart valve biopsy can also be helpful. You and I both took care of a recent patient with AS who'd undergone a heart valve surgery and then later was diagnosed with potential TTR, but did not have enough sample from a fat pad biopsy to type it. And we were able to type the heart valve biopsy tissue that had already been done a year or two previously and prove that the patient had TTR amyloidosis. And certainly we want to consider amyloid when we're looking at our patients with aortic stenosis, as you point out. I will quickly go back to the previous question that talked about, picking up things early. I think the second part of their question, which I don't know if we fully answered, was, will picking them up before symptom onset improve long-term prognosis? I don't think there's technically scientific data that says picking them up earlier will improve it, but it just obviously makes pure rational sense that if we don't start treating and our only treatment slows disease or reduces progression, if we don't start treating until later on in the diagnosis, then the patient will do worse, and we want to pick it up as early as possible and start treatment as early as we can.
Yeah,
so maybe
I was just going to say briefly on the aortic stenosis front. I mean, I think there is a reasonable case to be made that every patient referred for TAVR, or at least every man, because it's so much more prevalent, referred for TAVR, should have a evaluation with the basic evaluation when there's data that shows that more than 20% of men, all comers referred for TAVR, will have concomitant TTR amyloidosis, and it'll change your therapy.
So to piggyback off of that, what is your thought, Dr. Witteles, on treatment with either TAVR or amyloid therapy for these patients that are identified?
Yeah, I would say if they have TTR cardiac amyloidosis, then unless you're talking about somebody who's NYHA class 4 who wouldn't be in the study, then they should be started on standard of care therapy, which today would be tafamidis. The harder question is to know what to do with the aortic stenosis, and often these patients will be the low flow, low gradient patients who have some aortic stenosis, but maybe came to clinical attention with heart failure because of their amyloid, and then they were just found, that they actually have some AS. So you really want to try to get as good a sense as you can of how bad the AS is. But I'd say most of the time, if they have enough AS that they meet criteria for TAVR, our approach would be that to still do the TAVR and still to have every reason to believe that would hemodynamically help them.
Yeah, there were several, I completely agree. I think there were several studies specifically looking at this question of TAVR for patients with cardiac amyloid and AS that came out last year from the UK and Dutch groups. And they actually showed that the outcomes were actually, the patients with amyloid definitely had derived benefit from TAVR, but in discussing these studies with some of our TAVR cardiologists, I think it's important to look at the AS. And in those studies, it was basically high gradient AS that those patients had. And so they ended up having benefit. But as you said, a lot of our amyloid patients have low flow, low gradient AS. And so, even patients without amyloid may not derive much benefit from TAVR. So it's really important to get your valve colleagues involved to make sure that from a valve assessment standpoint, the TAVR makes sense.
Then I think to follow on with that comment, I would say, if you do identify amyloidosis in a patient with high gradient symptomatic AS, then you could anticipate that they're much more likely to need a pacemaker post TAVR. And there are other outcome measures that may occur higher in that population. So I do think it does matter to make the diagnosis in preparation for TAVR. So Ron, I don't know if you have a thought on that.
Yeah, for sure. I mean, we know the rate of AV block is so high in TTR amyloidosis in general, and then obviously TAVR puts an additional risk of that. So, obviously there's other signs like how long their PR interval is going into it. But yes, that's a patient where you should be very, very prepared for the likelihood that they'll need a pacemaker afterwards if they don't already have it.
Great. Thank you so much.
All right.
So I think we had tons of good questions and great answers. So we really appreciate your participation today. And I think that, we look forward to hearing from you in many different avenues over the course of the years. We always love having your talks. So thanks again, Ron.
Thanks for the invitation, man.
Thanks.
Thank you.